Maybe the panel can take a few minutes to bring some practical points about, this section was about diagnosing and managing astigmatism. I mean, not managing, but diagnosing and evaluating astigmatism. Priya, any comments?
I think that when you're getting started with astigmatism management, having a couple of different tools that you can rely on to sort of verify against as you're planning your surgery is very helpful. So I like to look at the topography, but I also look at my biometry, keratometry measures. And you really want to establish consistency. And if you don't see consistency across the devices, that should be a hard stop to go back and look at, for example, some of the things that Tony had pointed out, because very subtle pathology in the cornea can actually have a profound impact on accuracy of measures.
Another comment about starting with astigmatism correction, it's always fun to start talking about the details and the fine intricacies and multiple different measurements and with and against the rule. Reducing astigmatism is better than leaving a big amount. So if you're getting started, don't feel like you have to get a whole lot of investment. You know, a simple biometry, simple topography will give you enough basic information. Using toric IOLs is fairly straightforward. And we'd like to talk about the times we miss, but most of the time we actually do get pretty good. And I think it certainly improves the quality of life of patients. Certainly, if you're not currently trying to correct astigmatism, it's worth trying to start that in your practice.
And you can start really, really economically. And you don't, if you're not confident on it, start by not charging your patients and just getting a feel for how it works in your hands, and then you can escalate from there.
So speaking of low capital investment and getting great outcomes, I mean, what, if we could go down the line, and I mean, what lens calculator are you using? Are you using a toric formula, Abulafia? I mean, what is your go-to, Priya?
So for torics, I like to use the Barrett formula. I think that has given excellent outcomes. Devices, I use I have both a LensStar and an IOL Master 700 for my biometry, and I use an Zeiss Atlas topographer.
I also use the Barrett. We have a IOL Master 700, and we have a multitude of topographers that I use.
We use the Barrett, and then also use intraoperative aberrometry for fine-tuning that. And then most recently, we started using the light adjustable lens, which I think is going to be a great product that can help, sort of that barrier to entry. You might not have to invest in a lot of the topographies or preoperative diagnostics, and you have that ability to make sure you can hit that target postoperatively. So some great options.
I currently use the IOL Master 700 and the Atlas topographer. Before I had the 700, I used the 500. Before that, I used the IOL Master 5.4 or whatever it was, and I corrected astigmatism from way back when. So I think as we get better equipment and better measurements, our percentages are going to get better. But still, if you don't have the latest, you're still able to get pretty good results. And I think a lot of it is just thinking it through, looking for consistency. Personally, I do like to repeat, and I just use the same instrument twice to save me from having to buy a second instrument. And if you look at variability, that's kind of a quick and easy way of picking up irregularity of tear film or ABMD. When you see in 2 separate days or even 2 separate measurements, if there's more than a quarter or half a diopter of difference in your astigmatism or your refractive power calculation, that means you're going to have some fluctuation after surgery. So certainly that was worth looking at and treating or avoiding doing something.
The Barrett Toric online calculator, extremely important and such a huge contribution because it does account for a few different parts that lead to either perceptual astigmatism or ocular refractive astigmatism, because it counts for the posterior cornea as well as the effective lens position. If you don't account for the posterior cornea, our residual refractive astigmatism being less than half diopter, if you look at the literature, is only going to happen about 50% of the time. There are a few other ones, including the Baylor nomogram. Anyone here just using solo Baylor nomogram? And what about the Koch Abulafia regression formula using your favorite 3rd generation? So, I mean, it just shows you that really if you are diagnostically being as careful as possible and then using something like the Baylor toric nomogram, I mean, we can reach results where we have a residual refractive still after surgery of less than half diopter in over 90-95% of patients if we're doing it accurately. And then if you are the Dr. Bill Wiley and doing that number and volume where you can invest in things like Aura technology, that just takes you to the next level.
I had a question for the panel. It's not uncommon to see the patient who you plan at your toric surgery and you nail it. The lens is exactly on axis. It's the right power. It actually compensates. It compensates precisely mathematically for what's in the cornea, and yet the patient And you can even do a wavefront and show that there's no astigmatism in the eye. The patient insists on a one diopter toric lens for best vision. Noah calls it adaptive astigmatism or central astigmatism. What do you do for that patient? Do you wait, hoping that their cortex is going to catch up with reality? Or do you plan a surgery now that you might regret later? What do you do?
I can start. So for these patients, if they're an unhappy toric patient, I wait. And, in the beginning, there's lots of stuff going on. There can be corneal edema, inflammation. But if you are checking a refraction and the refraction is serially off, you've checked a wavefront, your toric is aligned. I can't say I know why, why it is that way, but I think this is where it helps to just have some, either if you have laser vision correction skills or a colleague in your office doing a PRK or something like that can be helpful. Going to Astigmatism Fix can also be helpful if you're not sure if rotation could be helpful. Astigmatismfix.com is a free website. You can type in all your pre-op and post-operative information, and it will tell you if rotation will help you in that scenario.
Well, the question is, if they have clear rotation or misalignment, that's easy. It's the patient who you are convinced has no objective astigmatism,
Totally.
astigmatism by, say, wavefront or by your calculations, and yet they're asking for manifest astigmatism.
Absolutely.
The question is what to do with them. They are the hardest subset of all the patients that we operate. You nailed it, and yet they're asking for correction.
Dr. Miller, you're absolutely right. I mean, we see that all the time, especially, let's say, for example, our LASIK patients, where one or the other is happening, especially if you've got a higher amount of withdrawal. Let's say topographically, you see 2 diopters, but they are only taking 1 on manifest refraction, they only take it. And then you're tricked into treating only 1, and then, afterwards, another 1 comes out. So there is something about perceptual astigmatism. Same thing goes with concept as it regards to cataract surgery. And in my hands, I mean, I will go somewhere in the middle, maybe not use a toric lens implant, but at the end of the day, you have to have that chair time discussion because there is a discrepancy that occurs. There's not always really consistent alignment, and sometimes refractively, their astigmatic axis or meridian is exact opposite of what you're getting on your diagnostics, so there are conundrums.
We've talked a lot about the science of astigmatism and the science of correcting it. The one thing that we really haven't touched on, of course, is the art of medicine. And it starts with the first time you see the patient and building that rapport preoperatively, doing the assessment of their personality. And when you have an outcome that's unexpected or off and not what you wanted, is ultimately you assess, how happy is the patient. And the end goal is 20 over happy. And if they have the astigmatism that you can't account for objectively, but from a subjective direction they want it, I would correct it. Typically, I wait 3 months after surgery for stability in general from healing. So if they haven't adapted and there's something that they really want, I would give it to them at that point.
I tend to wait on these patients way more than I'd wait on anybody I'm clearly off, the lens is off axis. I would intervene pretty quickly. But in these patients where I know it's right, I'll just wait. And sometimes the astigmatism will just slowly go down. If you try to jump in too early with a PRK or LASIK touch-up, you're going to end up ultimately correcting them so that that astigmatism may come out later on.
How long are you finding it takes for them to adapt to that?
I've seen it take a year and a half. I mean, it can be a really slow process.
So we're going to move on to the next section. Before we do, I just want to emphasize what Dr. Adave showed, that picture where he had diffuse illumination, the cornea looked perfect, and then oblique illumination and subepithelial fibrosis. I see it all the time with EBMD and mild Salzman's. And Tony, the mistake I see is that the residents come in and they put the beam narrow on high mag and miss everything in the cornea. So one look at the cornea, low mag, oblique illumination, that's the way to look at a cornea. So excellent discussions. We'll move on to the next talk.